早晨，聽唔聽到啊？
係聽到聽到。
聽到睇下先。呢個 background 好煩，後邊有個人頭嘅，你睇下。即係我要 cover 住呢個人頭先得，如果唔係就會有兩個人噶啦。咁咧，我睇下啲 slide 先。而家係咪啲 participant 未入定入咗啦？
入咗啲噶。我哋9點仲有1分鐘。
OK， 我睇下啲 slide
好，咁一陣間我開場白少少，然後再介紹你，然後再開始。
好，我 run 啲 slide 睇下係咪順。
係。Joey，係。你可唔可以 send 條join participants join 嗰條 link 俾我？有人。好得，冇問題。嚇，唔該晒。唔該晒。
咁就 Joey 就叫我講長少少嘅。
我哋而家你得先啦，開始咗啦。OK， 唔緊要啦。So, okay, should we start? Okay, good morning. Welcome to the seminar on newborn metabolic screening update, which covers 3 perspectives today, covers clinical, laboratory, and counseling. I am Jessie. I'm the Associate Professor of Midwifery Practice in Midwifery in the Chinese University of Hong Kong. I'm today's moderator. I'm delighted to tell you that we have actually over 800 participants today, and including local and overseas audience. So we have 3 speakers today. The first speaker is Dr. Josephine Zhang. Dr. Zhang is a clinical professional consultant and associate professor of practice in medical genetics, Department of Pediatrics and Departments of Obstetrics and Gynecology in Chinese University of Hong Kong. She is the pediatrician in charge of the newborn metabolic screening program. Dr. Zhang is also the Deputy Clinical Director, the Chinese University of Hong Kong Baylor College Joint Center for Medical Genetics. She is now the president of the Hong Kong Society of Genetic Counselling, as well as the chairlady of the Hong Kong Society of Medical Genetics. Her expertise is in undiagnosed genetic disorders, neurometabolic genetics, and inborn errors of metabolic disorders. With her outstanding academic achievement and significant contribution to the community, she was accredited as one of the five first fellows of genomic and genetic pediatrics subspecialty by the Hong Kong College of Pediatricians and awarded the 10 Outstanding Young Persons in 2018. And Dr. Zhang's topic today is clinical presentation of newborn metabolic conditions. Dr. Zhang, please.
Oh, thank you. Thank you for the organization inviting me to deliver the lecture, and thank you for the Hong Kong College of Midwife, and also thank you for Professor Lai for the nice introduction. So today my topic is focused on the clinical presentation of newborn metabolic conditions. So can you see the slide in the presentation mode now? Jessie, is it in the presentation mode? Yes. Okay, thank you. So besides the clinical presentation, because I was told to give a little bit more about the introduction of the history of IEM and also a briefing update of the newborn screening. So today for my learning objective in the coming 1 hour or so, I will tell you a little bit more about some of the history of IEM, and also we'll go to a quick revisit of the newborn screening program, and then I will share with you some of the cases that presented in our unit and some of the cases that we have seen in the past. So for this case is a real case that happened at around like 8 years ago. This term baby presented in Prince of Wales Hospital postnatal unit on day 1 with a hypothermia. So this patient had an unstable term, and the nurse at that time tried to wrap up the baby, put into the incubator, and then recheck the temperature. And later on, the temperature was okay, and the baby seems all fine. And then we just don't think the baby is having any suffering from any IEM at that time. So the nurses just keep the baby put on BF. But then the baby developed another episodes of hypothermia. So usually we should be alert if the patient presented with unstable temp again and again, not just once. Soon after that, this patient developed bradycardia and required resuscitation at the postnatal ward. But she was lucky because of the house officer at that time just had the rotation of pediatrics. That's why the house officer immediately helped for the resuscitation. And the patient was transferred to us and diagnosed having a condition called CACT. Is a very rare IEM conditions. So when you have heard about like sudden death in postnatal ward or in A&E or at home, then you may think of patient may be choking, or patient may have SCID, or patient may have IEM disorder. So IEM, this term seems is like a very difficult terms to many people, but then you can simplify to understand actually it is describing the enzyme that happen in your body, try to digest the food and then make it into a very useful energy to us. For example, this is a simple pathway talking about the analyte A and then further digested into analyte B and then to C. If there is something wrong about the pathway, for example, from B to C, if B cannot convert it to C, then C will be diminished. So if C is a very useful, or if C is a product which is providing energy to your body, that means that you are in a lack of energy. So if B is a substance which is toxic to your body, then it is also accumulated. So it all depends on which pathway that is having a defective protein or defective enzyme. So it depends on which kind of toxic analytes accumulate in your body, and then the patient will present accordingly. So IEM is not a new term. It had been described since more than 100 years ago. So this is a little bit about history. I find it very interesting to understand actually IEM is not a new term, and how the clinician discover it like at around 100 years ago. This is Professor Archibald Garrow, that he is a British physician, that he firstly described that actually gene can affect the enzymes function, and then later on we'll have a physical sign. And this paper was published in Lancet in 1902, and this is the first time giving a lecture of the concept of IEM, so people understand that when there's something wrong with your gene, then the pathway in your body may have something wrong, then it will turn into a phenotype. And later on, another physician, a professor, that he described the two children having severe intellectual disability with a special smell in the urine. And then he tried to test the urine with some biochemical testing and showing that that patient actually had raised metabolite, which is called phenylpyruvic acid at that time. And then later on diagnosed that the patient had phenylketonuria, which is the term that we use nowadays. It's a PKU condition. And then later on, he tried to test for the other patients who have intellectual disability, find out that actually some of the IEM disorder could actually lead to intellectual disability, which is a long-term poor outcome of an untreated patient suffering from PKU. So you can see this is in 1934 at that time. And then later on, there are two physicians. I think this is the time about like after the World War II. They have this find out patients having PKU, and this patient is called Sheila, and then they try to give Sheila a low phenylalanin diet, and turn out that it really modified the outcome of the patient. So this is the first time being described a treatment with a dietary modification could actually help to turn the outcome of the patient. So it completes the pathway that when you present it with abnormal analytes, you identify the patient and then you treat accordingly, actually the outcome could change. So with that, Professor Robert Guthrie, that he had cousin, I think a nephew, also suffering from PKU. He's trying to discover a method which they can identify patient early on. So this is one of the first newborn metabolic screening being described in history, is using a Guthrie card. You can see the driver's spot card in the middle is named after him. That using the driver's spot card, we can identify asymptomatic newborns who had the phenylalanine, which is elevated, and then you can use a dietary management to treat the patient earlier on so that the patient will not have intellectual disability. So you can see this paper is published in 1963, so it is more than 16 years ago. And Hong Kong, not until 2013, we still do not have PKU screening. So we actually, Hong Kong was quite lag behind in the field of newborn screening. So in the other programs in other developed countries, they have tried to use different methods, try to include different kinds of IEM, which is treatable and which the outcome will be ordered in the newborn screening program. And you can see later on in 1990s, tender mass spectrometry was discovered, and this method could actually test many diseases at one time. So the timeline for the newborn metabolic screening is actually happened in US first since 1963, and then later on with the new development of tender mass spectrometry, other countries including like Canada, Australia, Germany, they also have different types of expanded. They use the word expanded, that is to describe that in the screening panel, actually they're not testing for one condition, they're actually testing for more than 10 or several conditions, which is under the columns of IEM into the newborn screening. And PKU actually in China also been putting into a mandatory condition that they need to screen in year 2000. And for Hong Kong, up till year 2013, that we started to have not a mandatory but an opt-in newborn screening testing for IEM conditions, including the PKU. So this is one of the paper being published in 2015, mentioning about different newborn metabolic screening program in worldwide. So if you're interested, you can get back to this paper, which is not so updated, but then this paper is very good that they cover all the different programs in all over the world. And you can see in the small print of this table, Hong Kong is on the 5th line. And at that time, Hong Kong is just reported to have the screening of congenital hypothyroidism, which is the TSH testing using cord blood, and also the G6PD testing. So I think you all may be very familiar with the G6PD and also TSH, because it's using cord blood that you will have the callback system from DH sending you back the abnormal or borderline result that you may need to repeat. So this is the concept of the newborn screening. Actually, we screen some patient out. Some of the patient is really a real patient, but some of the patient may not be a real patient, that you need to do repeated testing to confirm whether they are just a false positive or whether they're really a patient suffering from IEM. So with that in mind, that you understand the importance of the newborn screening program. And so how many IEM conditions should be put into the newborn screening items? I think this is a selection criteria for the IEM's condition to be put in. There are more than 1,500 IEM conditions, not all the conditions to be put in. Only those conditions having an asymptomatic period, which you can use testing, which is easily can find out the patient is suffering from it, which is reliable, and also early diagnosis will benefit the outcome that you can put it in. So if someone asks you, is it better to screen more IEM condition at newborn screening period? The answer will be no. For those conditions which is not treatable, that means you do not have a very effective treatment for the patients, actually you may consider not to put it into the screening program. And this picture is showing you that in the past, you can see on the lower line that you see the book on the left hand side, IEM is just one chapter in the book, and later on with more genetic testing and biochemical testing, more IEM conditions have been identified. And then later on, you can see on the upper level that for volumes of the books, they are all describing just IEM's conditions. So not all the IEM's conditions should be put in. For those IEM which is severe, may be related to life-threatening condition, or those IEM condition which may be leading to a long-term consequences, such as intellectual disability, that will be considered to put in if they have effective treatment. All right. And the tandem mass spectrometry that I've mentioned have been discovered in year 1990s. It's actually a simple method that they use driver spot, which you put in on the driver spot cup. Actually 3 mm of the blood spot will be punched out and then put into incubation and then passing through the machine. Then just in 2 minutes time, then we will know about the different levels of the analytes. The reason why this is called tandem mass spectrometry is that it can test many analytes at the same time. This two table is showing you that what are the analytes that could be tested in one single testing. So on the column of amino acids is talking about the protein. If you take in protein, the food with protein, then protein will be digested, and then it will be digested into different amino acids. So this testing is telling you about the level of different amino acids, and then you will know which pathway is going wrong. Then we can predict actually which condition the patient is suffering from. And on the right hand side is a table showing acyl-carnitine with a lot of C, which is a carnitine, and then labeling with a number is the length of the acyl-carnitine. Then with different levels, we will know that whether the patient may be suffering from different of organic acidemia or a fatty acid oxidation defects. So with all that levels in mind, actually, we can tell whether the patient may have risk having these three groups of disorder: amino acid disorder, organic acid disorder, and fatty acid oxidation disorder. So if you're working in a unit of obstetric units that you may send patients a driver spot card for IEM screening, I think you should know about different types of, or at least different groups of disorder. Some of the disorders in these tables may present acutely, and some of the patient may not present acutely. Then you may not need to call back that patient at that night, so that the urgency and the presentation of the condition is really important. And for the driver spot card, we don't use the coupler because we want the patient to use their own system to digest the food so that we understand what is the ability of the infants. If we are testing the coupler, actually it is reflecting the mother's metabolic system, but not the baby's system. And also, while we are taking the driver spot card in the ward, actually the nurses from the phlebotomy, the help from the phlebotomist and also the nurse are very important. With a good documentation, we understand the timing for blood sampling and also the patient's conditions, and also the callback system is also important. So it is important also to try to keep the blood in a horizontal level, with the blood spot cap being fully covered without layering, and then turn to the back of the paper. There is a totally penetration of the blood spot, then we can use that level to for punching. If there is layering or inadequate blood spot, actually it may result in a poor quality driver spot that the patient may be underdiagnosed or overdiagnosed, and also may lead to a delay. So what if some of the patient may present on day 3 or day 4 if there is a delay due to a poor quality driver spot cut? So it may the patient may lose the chance for early treatment. So all these are actually very important. So the involvement of the phlebotomist and the nurses in the whole newborn screening logistics are very important. Okay. And so we use blood instead of urine because blood is a gold standard, while urine, we don't have a worldwide large database for good reference, and sometimes it may increase the false positive result, and so as it will also increase the parental anxiety. If it is a false positive, then we may need to repeat and call back the patient. So without a good database or good references, that type of testing, we can use it as supplementary testing for confirmation, but not as a good screening method. So right now, blood is still using as a gold standard. So we expect that more than 89% of the newborn who go for newborn screening will be normal, and only less than 1% will be abnormal. So for the uncertain one and abnormal one, we need to call them back, because we understand the screening panel, we understand the analytes, and then we understand what this analyte is representing. And some of the conditions are urgent, and some of the conditions are not that urgent. So for the urgent condition, we need to call back the patient on the same day, but for the not that for not non-urgent conditions, we may need to consider to call back the patient just the day before the testing available. Okay, and also we also need to understand the limitation of the screening testing. Sometimes some very mild condition or some of the carriers may be identified. And sometimes the patient, even though have a normal screening program, later on they still presented with IEM condition such as citrine deficiency. It is well known that citrine had a false negative, a relatively high false negative ratio, so that some of the patient may have a normal newborn screening, but later on they presented at 1 month old with prolonged jaundice and deranged liver function, and later on confirmed with citrine deficiency. So the sensitivity and specificity is not 100%. So this is one of the information that the patient and the clinicians need to know. So while we are preparing newborn screening program in one center, you need to know whether there is any available testing or treatment in the unit, because some of the testing, such as the loading testing, confirmatory testing, they could be very specific. And some of the treatment, which may involve special milk formula or tailor-made TPM, which may not be available in some of the regional hospital. So without this, actually that center should not be a callback center. So the callback center should always get prepared for special dietary modifications, special medication that could treat, such as the anti-hyperammonia medications. Because the patient, when you call back the patient with, for those with urgent presentation, sometimes ammonia could be very high, that you need to start off medication while waiting for the dialysis. Because those time, like 1 to 2 hours before hemodialysis, still a golden period of time which you can bring down the ammonia to a safe level using medications. So these are the treatment that need to be prepared, even though there is no positive case. If it is a callback center for newborn screening, all these dietary and also medications should be get prepared. And of course, the acute decompensation may need NICU support and also renal team support. So this is a collaboration between not just the ICU team, maybe a renal team, and also the colleagues should need to know that you may have this kind of patients suddenly come in. And I think this part, Diana, later we talk a little bit more about how will you manage with you callback a patient, what are the flow chart that will be useful for you. Different analytes is actually representing different IEM conditions. So it is quite specific that you need to understand what are the condition that you are handling. So the callback, the rate to, the timing is actually very important, how you handle the different analytes. And the last elements that you need to know, but not least, is that you need to also to understand the parents' response. Sometimes the parents may anxious about the result, but sometimes, unfortunately, they may have a misunderstanding about that. Say, for example, we don't have a positive patient in our family, even though with uncertain or abnormal result, we don't think the patient is suffering from IEM, which is very rare. And then they may not want to come back on the same day. But if it is an urgent metabolic conditions that you really want the patient to come back, sometimes you may need to spend some time on the phone to explain to the parent that the presentation could be very quick and acute, that it could be life-threatening. So, of course, all these counseling should be tailor-made and also specific to that analytes. So for non-urgent condition, we will inform the parent like 1 day before the clinic available. But for urgent case, we will call the patient back immediately. All right, and here comes the second part of the presentation. I would like to show you some of the cases. in the postnatal ward, sometimes you may encounter patient with neonatal arrest. The patient could present it with cardiac, or the patient may present it with respiratory symptoms. Sometimes some of the cardiac conditions could be very acute, such as patient may present it with cyanosis, with structural cardiac abnormalities, with arrhythmia, which is related to the electrical system abnormalities. And sometimes it could be due to IEM disorder, which the patient may also present it with arrhythmia and sudden cardiac death. And some of the patient may present it with respiratory symptoms, but then it is very difficult to distinguish whether that respiratory distress is related to this source of condition, or could it be related to IEM, which is associated with metabolic acidosis and metabolic alkalosis, which the patient will also present it with respiratory symptoms. So there must be some underlying genetics conditions involved. But then while we are seeing the patients, sometimes it's very, very difficult to decide, such as a patient that I have told you just now, we presented with unstable temperature. What do you think? Should you just admit the patient to ICU just while the patient presented with 1 episode of unstable temperature or not? I think it all depends on the clinical experience. While you're seeing the patient with very mild presentation of abnormal signs or vital signs, you will see the patient whether the patient is hypotonic or whether the patient is in good shape with good tones and feeding is well. So it's not just one parameters that you're assessing. You're assessing the patient as a whole. As a patient with other vital signs that you need to also take into considerations. Some of the clinical presentations for IEM could be also very mild, like hypotonia, maybe just poor feeding, sometimes maybe increasing sleepiness. With metabolic acidosis and alkalosis, it depends on the levels. Sometimes the patient may present it with a compensatory tachypnea. Sometimes it may not present like that, maybe just presented at a later age. And some of the patient may have hypoglycemia. If it is severe, the patient may have seizures. And for bradycardia, tachycardia, the patient presented acutely, which may need resuscitations. And sometimes the patient may remain okay until the metabolites to a very high level, such as ammonia. If it is become a high level, the patient may present it with seizures or raised ICP. And sometimes the patient may present it with renal failure and then subsequently requiring hemodialysis. And all these could be very, very high at the very early beginning. So it's very difficult for the nurses to observe for the very tiny little hints in postnatal ward. But if the patient presented with repeated episodes, so try to assess the patient as a whole. And then we also need to think about whether this kind of IEM condition could present it with those symptoms I've mentioned. So this is a recap of the 3 big group of the IEM disorder that I've mentioned: amino acid, AA, organic acid disorder, OA, and FAOD, which is the fatty acid oxidation defect. So the first group I would like to talk about is the fatty acid oxidation defects. So this is a baby we have mentioned presented with hypothermia, right? So we already know that the diagnosis is CAC, which is one of the fatty acid oxidation defects. So this patient presented at around 38 hours of life with severe bradycardia after 2 episodes of hypothermia. So you can see that if we take out the notes and take a look, the nurses also mentioned not much spontaneous movement. So which is actually some of the sign added on besides hypothermia that we may think this patient may have something else, not just due to newborn for the unstable temp. And after patient was transferred, we identified patient with CACT condition and for the family, they have no family history. And this kind of condition is an IM condition without physical sign. That means without abnormal facial dysmorphism and without structural abnormality. Actually, just from the physical exam or the first visit, they cannot identify whether this is a patient or not. And of course, if you don't know if the patient a normal formula, then in this condition, the patient cannot tolerate normal formula, cannot tolerate breast milk. So that's why the patient had the accumulations of the abnormal toxic substance, and then the toxic substance leading to cardiac arrhythmia. And after patient was transferred, the milk is taken out, and then we just give the patient D10, and then we supplement the patient with something that he can tolerate. So you can see that the metabolic testing showed that this patient had metabolic acidosis, hypoglycemia, and also the ammonia just slightly raised. And then the newborn screening showing the C16, 16 ratio to 1, 18 to 1 acyl carnitine are all elevated. And then subsequently, we have done genetic testing and confirmed that both of the parents are carrier with the abnormal pathogenic variant on the SLC25A20 gene. And then we changed the patient's diet to MCT-based milk formula. So for these conditions in Hong Kong, actually, this is rare. But then in the past, we have also encountered patients with that. But all the patients, unfortunately, they all pass away because of the cardiorespiratory insufficiency. And at that period of time, newborn metabolic screening was not available. And metabolic screening is not that easy. So one of the clues is that this group of patients will present with hypoglycemia. And while you know about hypoglycemia in newborns, it is a reflex to check the urine to see whether the patient had ketones in the urine or not. Normally, for normal human being, if you have hypoglycemia, there should be ketones in your urine. If there is no ketone, that means it is a non-ketotic hypoglycemia. So for non-ketotic hypoglycemia, this is the important hints to point to fatty acid oxidation defect, which is a condition that you need to attend immediately. Okay, so whenever hypoglycemia that you encounter, try to think about whether you also need to test for the urine for the patient, because the patient could be presented with sudden cardiac death. Okay. Besides sudden cardiac death, they can also present with acute seizures, acute ammonia, or other metabolite abnormalities. So the FAOD is talking about a large group of IEM, and you can see the analysis is difficult to understand the symbol like from C0 to C18, C20 like that, but actually it's talking about the length of the fatty acid chain. So with the short chain, we're describing 2 to 4 carbon, medium chain 6 to 12, and then the long chain is 14 to 20, very long chain is 20 to 24, 26. So CACD patients having this C16 and 18, which is mainly the common sources from the animal and vegetables oils. You can see from this table. So for us, we have to adjust the patient's diet so that the patient is not taking in this group of energy source as the main source. So the patient can take in medium chain, but not the long chain. And then while we are taking out something that we need to supplement the patients with soluble vitamins like A, D, E, K, and to make sure that even though we have special diet to the patient, but then we are still making sure that the patient's nutrition is not affected. And fatty acid oxidation is important because it will produce energy inside the cell if the whole cycle is normal, because the ATP depends on the mitochondrial beta oxidations to generate. If your body is in a lack of ATP, then of course the patient may present with hypotonia and also lack of energy. And then you can see that the glucose is also not able to go through the pathway to the acyl-CoA to generate for further energy. And sometimes we supplement the patients with carnitine because the carnitine can get through the transporter of the plasma membrane and then get into the pathway. It is a source from the red meat. Sometimes the level is low that for the vegetarian. So that's why in the history we will also ask for that. And carnitine is is indispensable for energy metabolism. It actually activates the fatty acids to enter the mitochondria for beta oxidations. So for this group of conditions, FAOD, the treatment besides dietary modification, we sometimes will also give the patients carnitine as the medication supplement as well. So this is a very busy slide with different levels. So I think it's very difficult for you to understand, but I still want to show you so that you understand the different parts of the pathway, so that you may understand why this group of patients, they may present with similar symptoms, but then we're talking about different subgroup under FAOD, and the treatment is a little bit different. You can see from the top level is the plasma membrane that the carnitine gets through, and the long-chain fatty acid can get through the transporter, and then later on get in. You can see the CPT1 and CACT, CPT2, and then you can see the yellow circle, very long chain, VLCAT, MCAT, and also the blue ovals. And on different color ovals is talking about different translocator, transporter, or different pathways. So if there is abnormalities that may be involving the outer membrane or inner membrane or the TCA cycle, so the patients will have an ineffective fatty acid oxidation. So all these patients may present with similar physical symptoms or signs, but biochemically will be different, depends on which step is affected. So we can group the fatty acid oxidation defects in different groups. Some of it will affect the carnitine cycle, which is the carnitine uptake defect, and which is not that rare in Hong Kong. And later on, Diana will present to you some of the cases presented in Hong Kong with CUD. And the other group is mitochondrial beta oxidation defect, which is talking about MCAT, VLCAT, which is on the membrane of the mitochondria. And of course, this group of patients is also very rare in Hong Kong. Overall incidence is only 1 in 9,000, but then certain groups is more common in Hong Kong, such as the CUD and CACT, but we rarely see the MCAT and the VLCAT, but MCAT is actually relatively more common in the Caucasians. So we do have Caucasians in Hong Kong, so sometimes when we are seeing the result with elevated medium chain like C6, 8, 10, then we have to check whether it is Caucasians that may match, that the patient may have a high risk suffering from MCAT. So for the pre-symptomatic patients, that we can identify them through newborn metabolic screening. For those patients presented with symptoms, we can measure the carnitine level or acyl carnitine level in the plasma. So that's why sometimes we will order not a dry blood spot test, but the serum testing. And of course, functional testing, including testing the fibroblasts or the enzymes, could also be available. But then practically, we will do the biochemical testing plus the genetic testing. Then we can confirm the patient is suffering from this condition. And then we can further test the family to see whether we can offer prenatal or pre-implantational options for the patient if the couple would like to have a second baby. And also for those, unfortunately, who pass away suddenly, then post-mortem diagnosis is also important. So in that case, for patient if unfortunately they presented with sudden death, while we also suspect for IEM, so the blood sample is very important to collect it at the time the patient really deteriorate, because it can show us the acyl carnitine profile so that we can know about which analyte is elevated and which pathway is actually affected. So for those patients presented with sudden death, or sudden infant death, or presented with the following, such as acute metabolic decompensation, hypoketotic hypoglycemia, or liver problems, or cardiomyopathy, skeletal myopathy, then we may think of FAOD. Then the blood testing is very important. Some of the patients, they could present it with acute decompensation like CUD. They can present it suddenly to A&E, such as one of the patients presented to Prince of Wales Hospital suddenly at the age of 2, and then died at A&E. And then the postmortem find out that actually the patient is suffering from, oh no, excuse me. Sorry, I think there is a problem with battery. I need to go back to my slide. Wait. Okay. Okay. Yeah. And nowadays, because we have newborn metabolic screening, we can always detect this group of patients very early on. But sometimes we have encountered patients with low fecundity on the newborn screening, but then we are actually diagnosing the mother is a patient, while then the patient is not a patient. For those scenarios, for the patients, for the babies, actually the free serum, the carnitine, will be increased with time. But then the mother's serum carnitine levels will remain low. So in that case, we can treat the mother instead of the baby. And if the baby is not treated, usually they will present it with myopathy involving the heart and also the skeletal muscle. They may not present it until it just touch the threshold. Like, for example, the patient with dilated cardiomyopathy, if it is not that severe, usually they may not present it until suddenly they have an infection, which exacerbate the underlying conditions, and then the patient suddenly just had a very acute deterioration of the cardiomyopathy and then leading to sudden death. So this is one of the very common presentation for untreated CUD. So with this, so you can see this is a case report in the past from our unit that the patient was identified, and then they turn out the patient presented with acute metabolic conditions, just like Ryan syndrome, with deranged liver function, but turn out is CUD. So CUD patient may present with hypoketotic hypoglycemia, and also for the urine may detect the dicarboxylate excretions, which is normal. Then with these two features, it is important to test for it. So with the newborn screening program, I think it had already picked up more than 90% of the patients, but then it is not 100%. If the patient later on presented to you with cardiomyopathy, so do think of doing a test of serum carnitine and NSAID carnitine to identify that, because the treatment for this condition is relatively simple. You can just give oral carnitine supplement and ask the patient to avoid fasting. That means for infants or neonates, they should not have prolonged fasting like 6 hours like that. And then even the patient, if they need to go for surgery, you may need to put up D10 with not just to put the patient new by mouth, but then with supplements, and also maybe try to put the patient as a first case on the day of the surgical list. So these are the things that we can do for patient with it. With all these measures, actually patients with CUD should have a good prognostic outcome with the management that I have mentioned. And of course, genetic testing is also important so that we can predict whether the parents' next pregnancy will have 25% or not. So if they're carriers, then that's 25%. So in Hong Kong and local Chinese, the carrier rate is relatively high, 1 in 125. So so from our newborn screening program, we have also identified several patients with that. Okay, so because of time, I think we need to move on to the second condition, which is the CCT that I've mentioned. CCT patient with the real case I've mentioned to you. The reason why they can present it with sudden neonatal or infant death, mainly because of metabolic decompensation and also the underlying cardiomyopathy. So with the underlying cardiomyopathy, if suddenly there is a metabolic with a metabolic derangement, it may trigger off the arrhythmia. Then that arrhythmia could lead to sudden death. And sometimes it may be due to the convulsion, which is affecting the CNS system. It may also lead to sudden death in infant and neonate as well. So the neonatal onset is about 82%. They usually present very early on with very distinguished profile, which is the C16, C18 carnitine will be raised. And the mortality is very, very high if you do not treat the patient. So if the patient put on breast milk feeding or normal milk formula, so the patient will present it very, very early on. And the treatment is easy, but the treatment outcome is not that promising sometimes, even though you treat the patient, because the margin for the patients to present it with acute decompensation is very low. You have to give a very strict diet, because if the patient is not put on the medium chain triglyceride, then the patient may be in a lack of energy. If the patient is taking in the very long chain fatty acid, that may also trigger off the arrhythmia. So sometimes, even though the patient is identified, the treatment need to be very, they need to have a high levels of compliance to the treatment. So the treatment is not just giving carnitine as easy as you did, but then the dietary modification is a lifelong treatment that they need to focus on. So you can see from this paper, you can see the patients, some of them, they presented, all three of them presented with sudden cardiac arrest, but then you can see the timing of presentation range from 28 hours to 41. So it's very early on. It's also a challenge for newborn screening program, because sometimes the result may not be available before the timing of presentation. And you can see for these three patients, they all put in a formula of breast milk feeding. So in that case, newborn screening, I think sometimes may not help to identify this group while they're asymptomatic. But then with newborn screening, even though they presented, then you know about the exact diagnosis very early on. Then you can tailor-make or tune to tailor the personalized treatment for this group of patients. So that's why our patient who presented at around 8 years ago, he is still alive right now with relatively normal development milestone. It is mainly because of the newborn screening result was available very soon after he admitted to the NICU unit, and then we treat accordingly. All right, and then the next one is the MCAT. MCAT is not that common in Hong Kong, but then it's common in Caucasians. They may be asymptomatic usually, but then when they are symptomatic, it's mainly related to the energy, like a hypoglycemia. They will feel tired, and then some of them may have seizures, and some of them could present a very severe, could have a coma as well, especially when they have concomitant infections. So this group of patients sometimes may have poor compliance to their medication, because even though they do not take the medication, they feel that they're pretty all right. But then for this group of patients, while they have infection or while they are putting themselves on fasting, they could present it with acute decompensation. So these are the important message that we need to explain to them as well. So if they are treated with a relatively normal carnitine level, so such as if they take in the supplement, actually they could remain symptom-free throughout their life. So this is something that the patient need to pay attention to. Avoid fasting is relatively easy, because sometimes they may join some of the like a donation activity that need to avoid like more than 24 hours. They should avoid doing that. And also they can have a low-fat diet, which is not just healthy to them, it's also healthy to some of the other people, which is not suffering from IEM. So this group of patients will have relatively good prognosis after the diagnosis was made with the supplement. So so I will not talk too much about this, but then this is the local experience for us that we identify patients that is suffering from the MCAT, and then the patients, one of them is a Caucasians, and for that family, they have a few members, including the father and also 2 other siblings also suffering from MCAT. So they understand when they need to take in the medication, and then when they need to avoid fasting, especially while they're sick, they need to put in extra energy for the kids who is suffering from MCAT. So all these members remain clinically well. And for the other family, which is a Chinese girl which had a sudden death and they managed to save the urine, unfortunately, it is a post-mortem testing that we identify the condition. And then this family also had subsequently 2 other members in the family. We diagnosed the newborn who is not suffering from the condition, and then the parents are reassured. So with the genetic testing, actually, it is not just helping the proband, I mean the one who is suffering from the condition, it also helps for the further subsequent pregnancy, that we can identify whether the subsequent pregnancy is affected or not. VLCAT is not that common in Hong Kong, but then it is also fatal with neonatal cardiomyopathy. So this group also had elevated C14 to 16, so it is important to avoid fasting as well. So I will not go into detail of it because we don't have a real case of the VLCAT here in Hong Kong, but then if you encounter Caucasians in Hong Kong which have abnormal newborn screening with elevated C14, this is one of the group that you need to pay attention, because VLCAT is not that rare in Caucasians, and also they may present acutely with acute decompensation with hypoketotic hypoglycemia as well. So, so far I've mentioned a lot about fatty acid oxidation defects. So one of the analytes which could be abnormal is ammonia, which could be secondary or primary to the cycle. So why do we need to pay attention to ammonia, and why high ammonia level is important that we need to really get urgent treatment for a patient? Is that you can see in this flow chart, hyperammonemia will lead to astrocyte glutamine accumulation. What does it mean? Astrocyte is the brain cell. If the brain cell had a lot of ammonia leading to the glutamine accumulation, the cell will become swollen. So you can imagine if all the brain cells is getting swollen, and then the brain will become not enough space, so we call a cerebral edema. And then with this pressure inside the brain, it may compress on the brain stem. So this is life-threatening. If it compress on the brain stem, it may also affect the respiration and also the cardiac functions of the patients. So so this group of patients usually may present acutely, but then in neonates, the presentation is a bit different. You can see this diagram of acute presentation on the left-hand side and chronic presentation. Ammonia could have range. Sometimes it is elevated like several hundred, not above 400. But if it is chronic, it may affect patient presented with chronic symptom. On the left-hand side, you can see it may be affecting the visuals, the learning ability, the development, ability to thrive, or psychiatric illness. But on the left-hand side, you can see acute presentation is usually talking about very high level, like up to 1,000, about 400 at least. Those patients may present it with acute encephalopathy, seizures, or changing of LOC. But for neonates, you can see the presentation is a little bit different. It could present like a sepsis-like picture, maybe just a little bit hypotonic, unstable temperature, respiratory distress. So it can mean IM, but it can also mean infection, or it can also mean some other things. So for us, if we have heard about unstable temperature in a neonate, usually we will work up the patient to see if the patient is suffering from infection. We need to cover with antibiotics. And secondly, we need to think about whether the patient is suffering from any kind of rare condition as well. So it's not easy to manage when patient presented with unstable temperature. The nurse informs you about this. Don't just try to think about just wrap the patient without assessing the patient. Of course, besides iron conditions, other conditions other than infections, liver failure, GI bleeding, and decreased intake, so that it become catabolic conditions. So all these or drugs may also lead to elevated ammonia. So at bedside, sometimes we test for some tests that we can actually get the result earlier on, such as we can test for the bedside blood gas to see if there is any acidosis. We can test the urine to see if there is any ketones. We can test for the diuretic to see the hypoglycemia, and then we can test for the other results to send the lab, including the liver and also the ammonia. So we will have some differential diagnosis in mind. So these are the workup that we should do. So if we can do furthermore specific testing, including amino acid profile or orotic acid, of course, we can further distinguish according to that group of the urea cycle defect. But then at nighttime or at weekend, sometimes you may not be that may not be easy to get specific testing. So we have to manage accordingly. So if we manage a patient, we treat the clinical conditions, cover the infections, and then we try to take away the normal milk formula to see if we can put the patient on D10 and then make the patient become an anabolic status, so as to avoid if there is anything that patient cannot take in. But then later on, if you identify, then we can give back those important nutrition to patients stepwise. And if the patient suddenly collapse or really pass away, then urine testing, blood testing, and skin biopsy are the important specimens that you need to collect at that time juncture, because it may help further to delineate the underlying metabolic conditions. If this is taken later on, after, at the post-mortem testing, then I think it may not be that helpful. So a peri-mortem sampling with blood test, urine testing, or skin testing would be very helpful to identify the underlying metabolic conditions. So I think that's all for me to talk about fatty acid oxidation defects. So I would like to also just take the following 10 to 15 minutes to cover the amino acid disorder and also organic acid disorder as well, so that you may have a feeling about how this group of patients may present it. So this is a term baby with 8 kilogram discharge on day 2. Come back that we have phenylalanine result more than 1,000. So now I think you all understand that this patient may be suffering from phenylketonuria. Phenylalanine, where is it coming from? It's actually from the dietary protein, and then with the cofactor BH4 and the enzyme phenylalanine hydroxylase, it will turn into tyrosine. On the right hand side, you can see tyrosine will further turn into dopa, melanin, thyroxine, and catecholamine. And all these are very important to the brain. So that's why if the patient had a defective pathway, they will not have enough tyrosine, and the brain development will not be good. So that's why in long term, they will have an intellectual disability condition. So if the pathway is not going to tyrosine side, the phenylalanine will accumulate in the blood. So it will be very high. And the phenylalanine will turn into the phenylpyruvic acid in the urine. So you can check that in the urine. So this one, with the first result, more than 1,000, we'll name it not just uncertain, but an abnormal result for newborn screening. But then I would say that this is a non-urgent condition that you don't need to call back the patient at midnight. The reason why it's not urgent, that if you can start off the treatment within 10 days, it's still acceptable for the outcome. And it all depends on the local setting. But in Hong Kong, on weekend, we don't have the loading test available. We may not be able to do confirmatory testing. So even though we admit the patient on weekend, we may not be able to give the patient confirmatory testing. So in that case, we do not want to make the parents worry for a few days before they can be admitted. So we'll inform the family on Sunday and ask them to come back on Monday. So if you have a result on Friday, of course, you can do it like that. If you had a result on Monday, then you can inform the patient to come back the next day. Okay, and this patient, later on, we check the phenylalanine is very high. You can see the reference range should be less than 91. And for the blood result, this patient had a level 1,900. And then the urine is also compatible. The urine is showing phenylalanine pyruvic acid. So the diagnosis of PKU can be made clinically just based on the clinical biochemical testing. But of course, we do further confirmatory testing and find out the gene is also have two variants, one from each of the parents. So the parents are asymptomatic carrier. And we have done the loading test, which is negative. That means this patient's enzyme is really, really low. So we need to put the patient on a low protein diet and also the PKU formula. You can see after we put the patient on the restriction, the phenylalanine dropped from more than 1,000 to several hundred. And then after we put the patient on the PKU formula, that the phenylalanine remained low. So we need to keep at a level below 320, that would be fine. And then you can see the tyrosine level is increasing. The reason why it's increasing is that the special formula not just have very low level of phenylalanine, they will give the patient extra tyrosine as a supplement. Okay, and which is an example of the amino acid disorder. So what about the organic acid disorder? So organic acidemia can present it acutely. So this is a term baby. AN was normal. Perinatal developed pool feeding at the age of 48 hours. The mother, this is the second baby of the mother. So the mother could feel that there's something wrong with the baby and ask for transfer to pediatrician. And after admission, we can notice that the patient had metabolic acidosis, and then the patient soon afterwards was intubated and also put on IVF. And then metabolic testing showed that the patient had elevated C5OH. So I don't think you need to note about the details of each of the pathway, but then with this in mind, we understand that organic acidemia could present it very early on. So if you are handling the newborn screening result and patient was informed you that a patient will have a C5OH result elevated, what should you do? And you need to think about whether that analyte is related to condition which may present acutely or not. So for C5OH, there are a list of conditions related to these metabolites. Because this is the branching AA pathway, that there are so many steps that may also affect the C5OH to be raised. So you can see that these are very long term for the biochemical analytes. I don't want to confuse you, but you can see that I have labeled the enzyme which is in red on different pathway. So there are several enzymes could be wrong in the pathway, but then the patient may present it with C5OH like that. So some of the conditions are very, very mild. We don't want to identify the patient, but some of the conditions we really need to treat the patient early on. The patient may need supplements. So we will call back the patient, do further investigations, try to play on the safe side, and then to see whether the patient could continue the feeding or not. And then confirmatory testing, including the genetic testing in this group of presentations, are really, really important. And some of the conditions we may need to do further special assay, like the biotinidase assays, and that may not be included in some of the newborn screening panels that we need to order it like that. And so this is another example for organic acidemia, also a term baby, which the AM was remarkable, NIPT was normal. Perinatal condition was also normal. He was born by spontaneous delivery with Apgar score, which is 10 at 1 and 10 at 5 minutes. But on day 3, the patient presented with metabolic acidosis, and patient was kept new by mouth, intubated, put on D10, and then because the ammonia was also raised, they understand that it could be due to IM conditions, and then carnitine was also given. And then the ammonia was raised to a very high level. It was in Prince of Margaret Hospital at that time. The patient was put on renal dialysis, and they have consulted our team on day 8. And at that time, we tried to ask them to top up the carnitine, but then it was actually too late because that patient already presented early on. The ammonia was so high, it already affected the brain with a very high intracranial pressure because the cerebral edema was very severe. So the patient also presented with renal failure as well. So even though with dialysis, which bring down the ammonia level back to a normal range a few days later, but then the patient still pass away because the brain intracranial pressure and the brainstem compression, which is a life-threatening condition, which is irreversible at that time. So later on, genetic testing was performed for the parents. They are asymptomatic carrier. So this patient was encountered at the age without newborn screening. So you can imagine how patient presented and how difficult that the clinicians that they're facing, they have no clue about which group of disease that the patient is suffering from. They did not think about that actually the ammonia could be that high within the brain, leading to cerebral edema within such a short period of time. So newborn screening could really help this group of patients. So this is another patient with similar presentation, but he is relatively more lucky that on day 2 screening, find out that the C3 is elevated, the amino acid is normal. So with C3 elevated on a newborn screening, what does it mean? It means that this patient may be suffering from propionic acidemia. The patient may be suffering from MMA, which are the 2 conditions that I've mentioned could be a medical emergency. So the patients that I've mentioned to you in another hospital passed away is suffering from MMA. Later on, we diagnosed the patient having MMA, and then the patient presented with very high level of ammonia and passed away. And for this patient, he's lucky because it was very early, it's day 2 only. So we understand that with this abnormal C3 result, this is an urgent medical emergency, right? And then we understand that the patient may develop high ammonia level anytime. And also with metabolic acidosis, we need NICU, we need hemodialysis, we need all the medication which could bring down the ammonia, get ready in the unit. And we may also need to get ready the renal team for hemodialysis. And most importantly, we need to explain to the parent that even though your child right now is asymptomatic, he or she need immediate medical attention. So make sure that the parents are willing to bring back the patient that evening or that night. So we can't wait for the next day. So we inform the parents immediately and then bring them back as soon as possible. So this patient may also have similar features with a neonatal presentation, maybe just a little bit sleepiness, a little bit sleepy earlier on, maybe the temperature a little bit unstable. So we need to grab the timing, the window gap that we can treat the patient, bring down the ammonia, reduce the chance for the cerebral edema. The reason why we want to treat it early, because from the literature already showed that not just if it is not just that important to bring down level, the duration of the patient suffering from high ammonia is actually strongly correlated to the brain damage. So that means the shorter the period of high ammonia level will be the better. So we need to treat early, make sure that the level is not that high, and make sure that the period of high ammonia should be as short as possible. And it also related to the prognosis. you see the prognosis is strongly influenced by the duration of coma and also the peak ammonia level. So bring down the peak is actually the key to help this group of patients. So I think because of time, I will end the presentation with this one last scenario that I would like to show you. This is congenital adrenal hyperplasia, which is a condition we also have added into the CUHK newborn screening program 8 years ago. This is a term baby, 3 kilogram on day 3. We find out that the newborn screening come back showing the 17 OHP is highly elevated. You can see it's 10 times more than the cutoff. So at that time, we already think that this patient may be suffering from CAH, and then we call back the family. The patient was in a private hospital, and the patients refused to be transferred to a public hospital. But then the pediatrician understand about the urgency of this CAH, and then we also explain to the pediatrician that the patient needs attention to the electrolytes, that if the patients insist not to come to our units, then you may need to do blood tests very frequently to monitor the electrolytes, because for this group of patients, they may have a sudden short losing crisis, which is life-threatening. But luckily, these patients, after the counseling from us and also the private pediatricians, they agreed to be transferred to our unit. And then we monitor for the electrolyte disturbance that night. And the patient really developed electrolyte disturbance, and we have treated the patients immediately. And then later on, find out that the parents are carrier. This is the autosomal recessive condition, 25% recurrent risk in the next pregnancy, and also in each of the pregnancy. So the parents are really grateful that we have spent time on the phone to counsel them, so that they, even though they don't want to go to a public hospital, but then they understand about the importance that they need to be managed in a unit with ICU care. And then the patient was treated. Because for us, we have encountered other patients having CAH. Unfortunately, they are not identified by newborn screening. They presented with short losing crisis, and some of them with concomitant, like one of the patients is presented with GE in a peripheral hospital, and after admissions within 48 hours, that patient died, not just because of GE. The patient also had short losing crisis because the patient is not put on the steroid supplement, and the patient had a post-mortem diagnosis showing that actually the had adrenal hyperplasia. So for those patients, they're very unfortunate. They could not benefit from newborn screening. But then we understand for this group of patients, even though with newborn screening, we need to know, we need to call back the parents and ask them for admission immediately, and don't wait for another night. Okay, so I think for the take-home message is that you understand how the patient could present it, and how you should manage for some of the uncertain newborn screening result and some of the abnormal result. You understand that the test could test for panels of analytes, but then this means a panels of disease that we need to get prepared for the testing, confirmatory testing, and also the treatment, including the ICU support, the renal dialysis, and also special medication as well. And most importantly is the communications with the parents, and also a closely working collaboration with other units, including the laboratory, the neonatologist, the nurses, and also the technician in the lab, so that they understand they need to urgently process which specimen, so that it could help for you to tune your management for that patient. The metabolic conditions could present with very mild symptoms to life-threatening condition with a short period of time. So newborn screening is one of the programs that could help them for early diagnosis and for early treatment, which could actually help for the prognosis. Okay, so thank you for your time listening to this presentation. If you would like to find more information, you can go online to CUHK websites, that we put all the information about our newborn screening program there. And for our panel, because it is also very important that we have added in a few conditions like SCID SMA, and ALD. So you can find all this information from the website. So I think I should end the presentation here to see if you have any question for the presentation today. Thank you for your attention.
Thank you. Thank you, Dr. Zhang, for your very informative presentation. And participants, if you have any questions, you can type in the chat box or in Q&A. I think we can see it. Awaiting the typing, may I ask the first question? And so, Dr. Zhang, I got two messages. We should think more about the two symptoms when the newborn presented with hypoglycemia and hypothermia, right? But nowadays, newborn may go home quite early with parents within 48 days after birth. Do you think we should, or how should we tell the parents, or should we tell them, well, I'm not sure whether we will increase their anxiety, how they observe hypoglycemia or hypothermia at home?
Thank you, Jessie, for the important question. I think it is very difficult for the parents to observe for hypoglycemia at home and also for hypothermia, because most of them may not know how to measure the temperature for neonates, and then they dare not to touch the neonate. And the temperature measurement using the skin is not accurate at all for the newborn. So I think it is unfair to ask them to monitor it. So for those babies, the neonate, if they really had episodes of unstable temperature or hypoglycemia that you worry about, I think the best would be to consult the pediatrician to have one more assessment before discharging the patient. Although it may increase the workload of pediatrician, but I think it's still a fair approach to assess those patients, especially while you're discharging the patient. I don't think it is reasonable to discharge a patient with unstable time, maybe just a few hours before discharge. So if you would like to discharge the patient early, just grab the pediatrician to have a visit before the patient go home. Sometimes the first visit could be very early on, then there may be a time lag. Say, for example, the first visit is done in the morning, and then the patient was discharged home very late in the evening. But then in between, if the patient presented with unstable temp or maybe episodes of hypoglycemia, I think it must you must consult the pediatrician to come to see the patient again.
Thank you. So some questions raised up, and as some cases reveal that both parents are the carrier after investigation, any suggestion on screening for pre-pregnant?
So if the patients have a genetic confirmation, sometimes we find out that the parents are carrier. So we will give the parents a genetic counseling so that we can explain to them they are asymptomatic carrier, and the next pregnancy will have 25% risk that the next pregnancy will be an affected neonate. So in that case, it depends on the approach and acceptance of the parent. Say, for example, the parent already got one patient at home, but then they feel that they are okay to manage this condition. For example, CUD, they feel that it is relatively easy for them to manage, even though their child is a patient. They just need to make sure the patient is not suffering from fasting and patient is having a medication supplement, then the patient is fine. They will not consider TOP. I think in that case, they do not need to consider a prenatal diagnosis or pre-implantational diagnosis. But then what they need is that diagnosis soon after birth. So in that case, we may counsel the parent to offer a genetic testing soon after birth, so that we will know whether the patient is, the next pregnancy, the next baby is a patient or just a carrier or normal. So if the parents may consider termination of pregnancy, if there is a recurrence of the same condition, then we can offer prenatal condition with the CVS or a minor or the amniocentesis, so that we can get the fetal cell for genetic testing. So we already got the genetic confirmation from the first baby, so we can easily check whether the next pregnancy is a patient or not. Of course, some of the patient may consider, the parent can consider IVF, so that we can choose for the embryo which is not affected. But then it all depends on whether that condition is a serious condition or not. Yeah. I hope this can explain a little bit to your question. Yeah.
Okay, thank you. And then another question asks if ichthyosis disease can be identified in the IEM screening.
Okay, thank you for the question. Ichthyosis is actually a symptom which is describing for the skin, which is thickened. The skin is thickened. It should be generalized or very diffuse in some areas of the body. So which could be due to several different genetics conditions. So right now in the IEM screening panel, I think all over the world, they will not mention they will screen for ichthyosis. They will just mention about the particular IEM conditions. So ichthyosis is a symptoms. Sometimes there is a genetics condition, but some of the IEM condition could also present with skin abnormalities. Say, for example, the biotinidase deficiency. The patient may also present with skin problem, which with diffuse redness and also some thickened skin or scaling as well. So that could be some of the symptoms of IEM condition, and biotinidase is in IEM screening as well. So so I think for this question, I think the answer is no to this question. Not all the ichthyosis disorder is included in IEM screening. Actually, most of them are not included. Just some of the IEM condition, they may have some skin symptoms, and those condition is named, each of them is also named under the panel. So I think basically the answer should be no. Okay.
Thank you. And any more questions? Okay. If no, thank you, Dr. John, for your nice presentation. Yeah. And before we move on to the next speaker, should we have 5 minutes break? So we come back 5 minutes later. That is 10:55. Okay, see you. Okay, so welcome back. So let's move on to the next presentation. The next speaker is Dr. Chloe Mack. Dr. Mack is a consultant of chemical pathology, Department of Pathology, Hong Kong Children's Hospital. She is also the council member of the Hong Kong Society of Genetic Counselling. Her education attainment includes PhD in the chemical pathology in the Chinese University of Hong Kong in 2008 and Doctor of Medicine in the University of Hong Kong in 2012. Dr. Mack has a lot of expertise, including newborn screening, Wilson disease, inborn errors of metabolism, chemical pathology, and genetics and genomics. Dr. Mack's topic today is newborn screening for inborn errors of metabolism and beyond. And Dr. Mack's presentation will be presented in a video recording, but she will be present at a Q&A session. So let's watch the video first.
Hello, I'm Chloe from Hong Kong Children's Hospital in the newborn screening laboratory for IEM. Thank you for the organizing committee's invitation. It's my honor to share with you our experience and practice in the driver sport-based newborn screening program in Hong Kong. The human biochemical pathway is very complicated and it's very amazing, created by God. And we know that IEM, if there is a metabolic pathway defect that will cause either products deficiency or toxic metabolites or substrate excess that cause a lot of problems. And it's a big group of disorders, phenotypically and genetically heterogeneous. And there are more than 1,000 genetic diseases involving in IEM. It can happen at birth, infancy, childhood, or late onset, or in utero. And sometimes, or most of all, the symptoms are quite non-specific. The patient can present with acute decompensation or chronic problems, and with the early and timely diagnosis management, the patient can subject to high morbidity and mortalities. So there are lots of IEM presentations, from failure to fry, neurological problems, unexplained episode of rare sepsis picture, to organ failure, impairment, sudden death, or in utero problems like acute hepatic liver of pregnancy or HEP syndrome. That can also be a indications or presentations of IEM. So it can affect any age, as we mentioned, and because of the clinical presentation is very wide and protein, and often makes the diagnosis quite difficult. And there's no universal screening test so far, and to screen for all IEM, the 1,000 diseases. Maybe one day with a better knowledge of genomics, technology itself is capable to do it, but the post-analytical part, like the interpretation of the variants, classification of variants, still need some time before that we can have a universal screening test. And so far, we don't have one to rule out or rule in all IEM. And also functional markers is still more important as well. So depends on your details in mind, you have to select the appropriate IEM test. So it's the past one with the color test, and which is most likely obsolete and less demand nowadays. In the laboratory, if you have a clinical case for suspecting of IEM, we will have the plasma amino acids, isocolantins, and organic acid, either performed by the HPLC, telemark, or GCMS. And however, these tests are quite laborious, as well as that the local labs are not designated for IEM. The same instrument may be used for drugs measurements or metabolite measurements as well, hormones. And therefore, sometimes it's quite difficult to cater for urgent need. However, most labs will try our best to try if you really have a case for urgent need, and you can always discuss with your local laboratory. And therefore, in Hong Kong Children's Hospital, or in past when I was in a tumor hospital and Princess Margaret Hospital, we launched the DBSM as a better first-line broad spectrum screening for clinical cases. So it is just one blood spot, and it can cover about 30 conditions in IEM. It is the same technique used in newborn screening as well in the clinical case high-risk screening. But for newborn screening, because we are target on the healthy babies, and so it is more selected to for which conditions to be included in the screening program. For IEM high-risk screening patients with already clinical indications, that we will be more extensive in the scope. So these are the analyses we include with amino acids, one organic acid, and also some fatty acids as well, which cover most of the locally prevalent amino acid, fatty acid, or stationary cycle defect disorders. So if you have a case, you can consult us, or you can send through your CMS or local laboratory with the DBSM request to us. And the sensitivity is high, about 99%, and it's convenient and easy to do it. And so we do recommend, if you're a case, you can lower your clinical suspicion threshold for the babies or patients at any age. You have those presentations unexplained or suggestive IEM, you're welcome to send these DBSM tests to us. So for newborn screening or IEM, as the conditions we mentioned, IEM is difficult diagnosis, and some can present with acute decompensation and high morbidity and mortality. But with early diagnosis, early treatment, and simple management, especially for those 26 conditions included in the local newborn screening program, they have good outcome. The cost effectiveness is proven worldwide. So, but in 2009, even in China, they had actually doing a lot better and earlier than Hong Kong. They screened PKU and also hypothyroidism and GSPD in southern populations. And in some advanced province, they have China mass spec for those conditions. And now they screen for up to 40 something. So with the newborn screening program locality back to 2011, there are public awareness that we need it, otherwise that we will miss some cases, they will die suddenly, they will have mental retarded. And so this was the first pilot study that with Hong Kong U Professor Cheng Nam and our team, together with more than 50 collaborators from 3 regional hospitals, PMH, Creo, and Actual Tumor Hospital, from OG, pathology, pediatrics, and IT colleagues that we try to conduct the feasibility test in Hong Kong HA public hospital settings. It's proven feasible, and also the papers and the models as OPAP surface model for expanded newborn screening in Hong Kong SAR is published. And also we also published the pilot study data in Hong Kong MJ in 2018 as well. And this is the OPAV model before that. So in the wards that we have the education, counseling, consent, and collect the drug spot, and send to the lab with the China mass spec, and then report to the specialist clinic with the metabolic pediatricians handling the positive results for counseling, confirmation test, diagnosis, treatment, and follow-up. So the committee is ready. We have a survey before, and the patient's acceptance is very well. And also on the other side, the CUHK also performed with the Georgia Helmet Foundation support. They have the metabolic screening is still running nowadays as a private service. So it's like we did a small scale of cost benefit analysis, taking PKU due to PTBS deficiency as an example. It also proven that implement this program is cost saving and life saving. So incidence in Hong Kong locality, we do not have a very comprehensive registry, but there are multiple efforts being made to address the incidences by 1 in a few thousands. And actually quite similar to other areas that they have a worldwide, nationwide screening program. Although the disease spectrum may be a little bit different, but the incidence overall collectively is quite similar. And so these are the development milestones that we implemented DBS clinicals as a high-risk screening service in Tumor Hospital, and then to PMH, and then not to allow referral from other HA hospital. And then we start with the Hong Kong U collaborations These data are convincing and helpful for the government to make the policy address. They support the pilot study in 2 hospitals, QM and QE, in 2015 to 2017. And it was a very good experience and collaboration with those expertise and professional healthcare from public health, pediatrics, OG colleagues, and pathology and IT colleagues, and also our administrator. That was a very amazing journey for us to pioneer the work together. And so now the service moved to Children's Hospital, and in 2020, we already implemented newborn screening for IEM for all public hospital babies born. So these are the membership on the task force work group. So the criteria for how we include conditions into newborn screening actually we still follow the Wilson and Junior classic screening in WHO. However, still some adaptations because the healthcare concepts and how the public receive screening program are a little bit changed. Some more remarkable is even there is not curable, there's no treatment. The public still quite welcome to be screened because they can have better family planning. They know how the prognosis is. They can cut short the diagnostic odyssey. So these are some changes in the screening conditions criteria. However, in our pilots till now, we are adopt a more conservative approach, strictly following more on Wilson Junior, and we classify into screening capability, clinical significance, available treatment, and also early treatment outcome. Most are quite familiar to all of you, I think, that because it's a Wilson Junior criteria. One point I'd like to stress on is the clinical significance that because IEM is individually rare, so we would like to include those conditions or consider those conditions have been reported in our locality. You know that some IEM we may not see 1 in 20 years, so that would be a less priority. However, we have a regular review exercise every 2 to 3 years. We'll review the literature, the worldwide practice, and the local data to we consider which conditions should be putting into discussion for screening or not. So from pilot, we have these panels. And these are the pilot's conditions that we face in. And after the pilot, we add 2 conditions because there are new cases coming in, being screened. And so this is the model we have. I've been discussed it. And for newborn screening, not just a lab test, is a whole program. So from pre-analytical, analytical to post-analytical, and short-term and also long-term evaluation is very important. So we have 10 steps, and evaluation is one of the important one that we rely heavily on our public health colleagues. And also for education, also very important, we rely on our OG colleagues to make sure the parents understand why newborn screening should be tested. And their expectation has to be managed because false positive is a known issue that can cause unnecessary investigation and parents' anxiety, especially during the postpartum period. And so how they handle the counseling education is very important, and which from the pilot to now is very successful. Our coverage is more than 99%, and there's very, very good acceptance. So I'd like to thank our OG colleagues for doing this hard job for us. And so these are the pamphlets we prepare for the parents and for the professionals. And also we have a locally made video as well, and it's zoomed. And these are my church mates that they help us to film the video as well. So we have very nice animations from that company. So the results of the pilots actually published it in Hong Kong Journal of Pediatrics. And so 99% baby consent to the pilot. And we found that expectedly incidence was quite high in 1 in 1,700. And the false positive rate is 0.3%, true positive 0.06%, and there's one case of false negative as well. And so it is aligned with international criteria. So we also have a different points to evaluate the standard of our program, like the completeness of coverage, timely chatted, the records timely collected, timely received by laboratory, and timely informed the test result to the parents. So that's okay with one incident of instrument failure at that time, but after pilot, it has been improved. So, and one condition is that abnormal result on the baby is actually a maternal issue. And so in newborn screening, it's known that we can pick up mother's conditions rather than a baby because of the maternal conditions. And the patient satisfaction is good. So that they understand why they have to consent for the screen. And this is an opt-in program. So most of the pilot study data are published in this series. If you're interested, you can go to the full text available online. And in our GCLS system, now you can see newborn screen for IEM. You also take it, just one of the tests inbuilt in the CMS system. I would say this is very enhanced and advanced version because when I visit other overseas newborn screening lab, they use a paper form and written form. So they have a lot of mechanical stuff to type in, and the nurse has to call back for missing conditions information. So that our system is nice for this aspect, very nice. So I thanked our IT colleague as well. So you can have a look in the lab tour. So when we receive your samples, we have to label each sample with a unique barcode, register their arrival and what tests they're being requested. And also we have a puncher to punch a 3.2 mm driver spot into a microtiter plate for analysis. And then we have the add solvent, add standard, extract the solvent, incubate the sample, and then shake it. So we have to do some transfer of the samples before it can be put into the mass bed, centrifuge it, and there will be a system to be punched. And after analysis, usually because we have about 100 to 150 samples depending on birth weight that year, we have to check every total iron chromatogram whether it is a normal shape before issuing the results. And our colleagues will check the QC and upload the results. And these are the laboratory information system worksheet that every pathologist are checking the results, whether this is normal, abnormal, and we have to add the comments and also add follow-up actions before we, like the second tier testing, before we issue the report or call the pediatricians for follow-up. And if it's all normal, you can see normal, that's easy. So pros and cons of MBS for IEMs is early diagnosis, treatment, lower the morbidity and mortality, avoid necessary investigations, help the families for planning and counseling, can detect some maternal disease like maternal cognitive deficiency, maternal vitamin B12 deficiency as well. However, there's some limitations, like there's lack of long-term evaluations. I think because newborn screening by tandem mass spec is introduced in the recent 2 decades, and we still need more long-term information. Some onset before, some cases will have onset before the MBS result is released, especially like MMA, and we do have patients have onset before the newborn screening results being released in MMA patients, and the outcome is not good. That's a problem because the newborn screening lab, some post some countries may have their newborn screening lab running 6 days a week or 7 days a week. But it is not just the issue of the lab, it's actually the whole team from pediatricians, the lab pediatricians, where is counseling. A lot of efforts have to put into. So that's still a limitation of it. But we now improve our collaboration with the pediatricians. If they have suspected case with the newborn screening test being results available, they can always call us, and we will try our best to cater for the clinical need by the DBSM samples or etc. So newborn screening is not 100% sensitive. They still have some false negative with mild or atypical cases, and they have false positive problems. And also they can be denied that they detect some condition that's doubtful significance and carrier status, but that's less likely nowadays because we have more second-tier testing to reduce the false positive or reduce the problems of carrier status being detected. So as I mentioned, there's just a collaboration between DH and HA, and we provide lab tests now for 26 IEM conditions. And since the 2020 October, is now covered all 8 public hospitals with maternity service. And newborn screening was more than a test; it's a multidisciplinary services. And now this year, we actually last year October we started another program. Pilot is the severe in combined immunodeficiency. So this is using a quantitative endpoint PCR reactions to measure the track copy numbers, which reflect anti-T cell deficiency. And we collaborate with our immunologist team. So from the scope, there are a lot different scope based on each country's practice. So like US, they have a core panel, and actually most of it we will include it, but not all. Like they have the sickle cell, which is that's coming in Hong Kong, and also they have cystic fibrosis, and now we have severe combined immunodeficiency as well. For SMA, X-linked adrenoleukodystrophy or MPS type 1, we do not have it yet, and these still have some discussion on it. Like X-linked adrenoleukodystrophy, rather we should pick up female because it's an X-linked condition, and female are usually asymptomatic or only become symptomatic in adult onset. So there will be more ethical issues has to be discussed. So for China, mainland China, government also now they propose 48 conditions by Tandem aspect. And so what's beyond in newborn screening, I think, is the application of NGS, next generation sequencing. So they are like in the babysit projects, they actually are not talking about genomic sequencing of all sequenced out, but more approach is like in China or in Beijing Children's Hospital, they are now using the targeted sequencing. So they look for long, well-characterized, likely pathogenic or pathogenic variants. So the yield will be much higher, and also there will be less false positive, less controversial. But I think you still have to be combined with the functional markers if that is available. Because sometimes if you found one variant, heterozygous variants, even it is likely pathogenic or pathogenic in a autosomal recessive conditions, it is difficult to say whether you should report it or for further workup, like to look for copy number variations, exonic deletion or duplication, or what. Because it carrier rate of these IEM can be 1 in 100, 1 in 300. So when you're doing a population screening, you might quite often encounter one heterozygous lone pathogenic variant detected. So I think the protocol should be disease specific if you are using targeted NGS protocol. So, but we should be expecting this technology changing or adding to the newborn screening program soon. So newborn screening is a public health issue, and every government should have a policy addressing how the population should be handled, what conditions should be screened, and how the resources should be allocated, and how the epidemiology data should be collected, reviewed. There's a lot of things to do, and we need a government top-down policy for that to be more comprehensive and for the best of Hong Kong babies in the future, our generations. So if you're interested more, you are welcome to visit our homepage in the Newborn Screening Lab. So these are colleagues. They are excellent colleagues. Thank you for them, and thank you for your attention, and thank you, God, for newborn screening. Thank you. May God bless you.
Thank you, Dr. Mac, for your presentation. And if any questions, you can type in the Q&A box. And okay, let me raise the first question, Dr. Mac. And may I know how long will the laboratory keep the dry blood spot card? Like the maternity case notes we keep for 21 years for possibility of legal medical concern. So what about the dry blood spot card?
That's a very good question. Thank you, Professor. And there's no universal consensus for how long we should keep it. Since the dry blood spot mass spec analysis service began in about 2 decades before, the commonest practice down there in the past was to keep until 18 years. And I have visited Texas Center University. They have a basketball court size storage area and have freezers for them, because if you really want to keep the samples integrity well, after 18 years for further analysis or whatever assays, except DNA. DNA is very stable, but if you want analysis, we should have to keep the samples in refrigerated storage conditions with desiccator. So it's a very heavy investment in space and also in the temperature, the freezers control. And however, there was some issues, especially Texas, they have a law issue, was that the lab sell the samples to a manufacturer for some research work or their product project, etc. And the parents later on sue the laboratory for doing that, because they claim the sample should be owned by the parents or the baby themselves, not the laboratory or even the government. So there's since then, most laboratories now I visited before, like in Europe or Germany or Netherlands, they usually store just a few years, up to 3 years or so. And most of them now just store it in room temperature. So after this reference, we have a discussion between ourselves in the work group level of newborn screening. And the major issue that we concern is about a proper bio-base to how to store. And we also need a government or a higher level policy to tell us how to consider pros and cons, who is the ownership of these samples. And if someone wants to retrieve these samples for like a research study, what's the proper mechanism to vet, to approve? And also, but it's of course, these samples are very valuable in the sense of like disaster identity tracing, but not so common in Hong Kong for disaster grade level that we need to retrieve and identify before the persons are the victims. And also for research or quality purpose. So because of lack of a very comprehensive policy direction, and we take a very conservative approach at our stage, we just keep it for 6 months. We promise to keep it for 6 months. Mostly it's for if there is really some false negative case coming up for IEM with infantile or early onset in neonates level, we expect within 6 months should be quite reasonable, although not completely encounter all atypical or late present cases, but will help us to retrieve back and look back again for whether the results false negative is due to analytical issues, sample issues, even swapping samples can occur. So mostly for troubleshooting. And but luckily for this moment, we have been piloting service since 2015. We do not receive many false negative cases. Mostly are the citrulline deficiency or the CH condition that is well known because the marker is not sensitive enough for these two conditions. So that's our current practice.
Okay, thank you. Very detailed explanation. And
thank you.
Any more questions? No more. Oh, no more questions? No. Okay. Thank you, Dr. Mac.
Thank you. Thank you all. Thank you.
Thank you. So let's move on to the third speaker. The third speaker today is Miss Diana Mann, sorry. Miss Mann is registered nurse in the Department of Pediatrics, Prince of Wales Hospital. Her main duty is to work as a genetic counselor of Hong Kong Genome Project under Hospital Authority in Prince of Wales Hospital Centre. Before working in HA, Ms. Mann was the nurse working in pediatric genetic clinic under the Chinese University of Hong Kong from 2018 to 2021. Ms. Mann is relentless in her studying. She holds double master degrees. The first one is the Master in Nursing in the Chinese University of Hong Kong in 2018. And the second one is the Master of Medical Genetics in 2022, this year, respectively. She is now the Secretary of Hong Kong Society of Genetic Counselling. Ms. Mann's topic today is the role of nurses in newborn screening and genetics. Diana, please.
Good morning, Dr. Zhang, Dr. Mac, Professor Lai, and all audience of the webinars. May I ask if anyone can hear me clearly?
Yes.
Yes, thank you. And then I will now share my PowerPoint slides. So may I ask if anyone can see my PowerPoint slides clearly?
Yes.
Okay, so good morning, Dr. Zhang, Dr. Mac, Professor Lai, Joey, and all the audience of this webinar. I would like to thank you, the organization committee, for the invitation and a nice introduction from Professor Lai. And I am Diana Mann, a registered nurse at the Department of Pediatrics. And currently, I am working with Dr. Zhang to coordinate the patient care in the Pediatrics Genetics Clinic and the Hong Kong Genome Project at the Prince of Wales Hospital. And with my work experience on the Chinese University Hong Kong Newborn Metabolic Screening Program, it is my great honor to take this opportunity to share with you all my experience in the newborn metabolic screening and how to integrate genetics into our practice. And today, my my sharing will cover an overview of the metabolic newborn screening and the role of nurses in metabolic screening, newborn screening and genetics. And then there will be a case illustration, and finally comes to the implications for nursing education and research. So newborn screening is a universally accepted and one of the first population-based screening programs that aims to identify and detect congenital conditions and early identification of these congenital conditions that are not readily observable upon the physical exam shortly after birth. It is crucial because timely early intervention could save the newborns from severe and irreversible complications, usually like intellectual disability and or even death. And newborn screening first began from the simple bacterial assay developed by the Dr. Robin Gruffy in the 1960s, and to detect the increased phenylalanine levels in the newborns with phenylketonuria, PKU. And PKU is an inborn error of metabolism and that caused by a genetic defect leading to the deficiency in specific enzymes that help metabolize part of the food. And then for PKU, it is an autosomal recessive disorder that results in decreased levels of the enzyme that converts phenylalanine into tyrosine. So early detection with strict restriction on the amount of phenylalanine in the diet intake is effective in preventing detrimental effects related to the enzyme deficiency. And with the advancement of the tandem mass spectrometry, levels of more than one metabolites can be measured by different mass at one time, and providing an indirect measurement of protein activity and acting as a proxy for DNA changes to suggest a presence of genetic condition. And nurses and midwives are key providers for newborn screening education and the communication of screening information to parents throughout the whole newborn screening process. And the International Society of Nurses in Genetics issued a position statement on the role of nurses in the newborn screening process in 2012, and then which recommends the following for nursing practices, including active participation in current knowledge of newborn screening as an advocate of for patients and families, and to provide patient education prior to the testing for newborn screening, and offer the post-test counseling, and then to explain the use of the results to the parents. And considered as the frontliners, nurses are usually the first contact of parents to the parents in a primary care setting or in a health facility. So it gives us nurses an opportunity to advocate and educate parents on newborn screening. And then given the inherited nature of the conditions that detected in newborn screening, mostly the inborn error of metabolisms, and it implies that nurses should be knowledgeable about the basic genetics concepts necessary to explain these conditions to parents. And driven by the advances in genetics and genomics, and these expectations from nurses contribute to the recommendations on integration of the genetics in nursing practices. And the American Nurses Association published the core competencies in genetics for health professionals and for the nurses, and especially respectively, and with both aimed to provide a framework to guide the integration of genetics and knowledge, skills, and attitudes into our routine healthcare. And there have been various initiatives to improve the competencies of nurses in genetics, and both in pre-service and graduate nursing programs and in service. And then genetic nursing practice and care focuses on the actual and potential impact of genetic and influences on health. And so newborn screening nurses can capitalize on these existing programs to integrate the above the mentioned elements into of genetics into our current practice. So I would like to introduce you all the CUHK newborn metabolic screening program, and screening for the newborn inborn error of metabolism is not compulsory in Hong Kong. And then the private metabolic newborn screening program was commenced by the Center of Inborn Error Metabolism of the Chinese University of Hong Kong since 2013 July. And then this program receives samples from multiple private hospitals. And while the government program by the Department of Health and Hospital Authority has been started since 2015, And then the CUHK program offered an opt-in screening for 30 kinds of amino acid disorders, organic acidurias, and fatty acid oxidation disorders. And in addition to congenital adrenal hyperplasia and cystic fibrosis and conditions of X-linked adrenoleukodystrophy, spinal muscular atrophy, and SCID, the severe combined immunodeficiency has been newly included in the panel since the September 2021. And from the July 2013 to July 2021, more than 83,585 local newborns were screened by the CUHK program, and 16 babies having different IEM conditions were identified. For example, like the carnitine, acyl carnitine translocase deficiency, the citrine deficiency, and the hypophosphatemia. And all patients are managed at the specialty clinic and were referred to the metabolic specialist clinic for long-term follow-up. And for this program, the overall incidence of IEM is 1 in 4,399, which is quite compatible to other local data. And the success of newborn screening program relies on nurses' key roles and responsibilities in ensuring appropriate information are given to parents, even during the pre-screening period, and to facilitating the transport of specimen to the lab and recall, follow-up, and manage of all those diagnosed patients. And here it comes to the simplified workflow of the CUHK newborn screening program for a baby receiving a normal report. And firstly, pre-test counseling and parental consent were done by doctors or trained nurses who are mostly from maternity and pediatric wards of the referring units. And then dropper spot card samples were collected from the newborns by heel prick on the filter paper between 24 hours and 7 days of life. And then the levels of metabolites were analyzed by the mass spectrometer. And then with a various level of metabolites within the normal range, a normal report will be issued, and meaning that the baby passed the newborn screening for all these diseases in the screening panel. So during the pre-screening education, newborn screening trained nurses will give parents the information about the purpose and the benefits of the newborn screening. The benefit will be identify the IEM patient and can offer timely management. And then we also will inform parents of the risk of newborn screening, as well as various disorders that included in the screening panel. And we need to remind parents that not all IEMs can be screened by newborn screening. And also, we will also orientate the parents about the heel prick procedure of collecting the blood spot sample. And after collecting the blood sample, and then parents are provided with additional resources, usually a brochure on the newborn screening, and then contact information, and should they have any questions later on. And then also for the interpretation of results, the possible results of the screening program will be normal, positive, or uncertain. A normal report indicates that the baby has a very low chance of having one of the IEMs, and the majority of babies, 99% of babies, usually will have a normal result. And then for positive results indicate that the baby is at risk of having an IEM situations. And we have to tell parents that if for a positive result, we need to have an immediate referral to the pediatrician for clinical evaluation, for the diagnostic workup, and management as needed. And then the third possibility of uncertain results will be indicating that the sample analysis is not conclusive and a new sample is needed. And then this may happen in 1% of all screened babies. And then therefore, we need to remind parents the possibility of callback for a second heel prick if the first sample showed an uncertain or positive result. And then regarding the accuracy of the screened IEMs, and then the accuracy of the screening program is high, but the sensitivity is not 100%. And then we have to also remind the parents that it is just a screening test, but it is not a diagnostic test. Therefore, any follow-up of confirmatory testing will be necessary for any uncertain or positive results. And also we have to let parents to know that they have an option of agree or disagree for the retainment of baby's residual sample for any anonymous use of laboratory internal use, medical research and publication. So overall in the pre-screening education, nurses are in a position that address not only the informational needs of the parents, but also the inherent psychosocial and ethical issues that comes with the screening process. And also it has been shown that parents who have been given the information about the screening beforehand have less stress burden and have a higher adherence to the follow-up in case of positive screening results. And this also allowed building of the trust and rapport among the parents, healthcare workers, and newborn screening itself. And then it also conveys respect to parents. On the other hand, here comes to the workflow for receiving an abnormal screening report. And when any one of the metabolite levels were out of the cutoff, and abnormal results will be released. And our clinical team with metabolic newborn screening pediatricians and nurses will be notified immediately for any uncertain screening results. Then the newborn screening nurse will be the one responsible for handling and calling back those abnormal results by informing the referral unit to request a second sample of the driver spot card. And if the second sample, the report is normal, we will inform the referring center that the baby will be considered as past the newborn screening. However, in case of persistent abnormal results, the case will be referred to specialty care for confirmatory testing to see if the baby is confirmed to be a patient or not. And then after informing the referring center about the persistent abnormal results, the newborn screening nurses will call the parents to inform them the results and arrange an appointment with the metabolic newborn screening pediatrician. And if the baby is confirmed to be a patient of a certain IEM condition, and he or she will be referred to the metabolic specialist clinic for long-term follow-up. And then the exact logistic will be based on case-by-case basis, and then depending on which abnormal metabolites and the related conditions. And then we will go over the role of newborn screening nurses on the results disclosure, the specialty care, and the long-term follow-up care to facilitate the genetics counseling in the newborn screening program. As soon as a positive screening result is received, and then the newborn screening nurse will get in touch with the parents. And then so you can know that we are often the first liner to inform the families and parents about the abnormal newborn screening results. And then usually we will use by phone. And then it is not uncommon that for healthcare providers to have insufficient understanding about the screening and lack confidence in speaking with parents about the screening results. And then with useful resources like the ACT sheet, the ACT sheet released by the American College of Medical Genetics and Genomics, we can always get a quick reference, a clear reference of the indicated condition of the abnormal test analyzed with the available tests and treatment. And then during the disclosure, we will provide parents the information about the specific disorders detected and gives the instructions of any confirmatory testing and offer psychological and psychosocial support to the parents. And at that time, over the phone, parents are often very distressed about the information of the notification of the abnormal results. And then parents at that time may present with various reactions and heightened emotions ranging from being shocked and surprised and to being anxious as the result of the abnormal report. And also accessing the internet for the disease information can also frighten the parents and then to increase their distress. So we can help them by guiding them to some credible newborn screening websites and engage them into some discussion together or some online information to release their stress. And then it is the main time for nurses to provide psychological support to the parents. And then besides disclosing the results, and we can also give information of the parents of the inherited nature of the possible IEM conditions that we can assess the patient's genetic risk by collecting the personal and family health histories when analyzing this information. And then obtaining a 3-generation family history can help us to identify the individuals and the family genetics risk factor of the related IEM condition. And firstly, we will start with baby's history and then to gather the information on the first degree, on the children, sibling, and parents. And then we can obtain the second degree, including the maternal and paternal grandparents, aunts, uncles, nieces, and nephews. And then the third degree, including the first cousins, relatives. And then for each family relatives, we will collect the information from parents of their relatives on their age, health status, including the medical conditions and the age of diagnosis. And then if deceased, for deceased family members, we will ask them the age of death and the cause of death. And then we will also ask about the race and the ethnicity of the maternal and paternal grandparents. And then after all data are gathered, we can analyze those information to determine any relevant IEM condition, which patterns on the mode of inheritance and then as a monogenic disease risk. And then we can draw a pedigree. It is a very effective way to visualize the family history information. And in addition, at the same time, we can assess parents' knowledge and perception about genetics and genomic information, as well as their responses and then their address them their any issues or concern. And then in addition to IEM, we also need to pay attention to several red flags in patients' personal and family history that may indicate a potential for some inherited susceptibility to a disease or genetic condition. And then both Genetic Alliance and National Coalition for the Health Professional Education in Genetics are some reliable resources to learn about those red flags. And then for primary care, cardiology, oncology, and other specialties have also some published data that specify the red flags in their specialty. And then when those red flags are identified during the family history taking, we need to alert our clinical team to make a suitable referral to a genetic specialist. Then the newborn will then be called back to attend our consultation in a specialty care center, which is the center to diagnose and care of the patients that pick up by the newborn screening. And then in the specialty care centers, multidisciplinary teams of geneticists, nutritionists, genetic counselors, and nurses are commonly employed because of the complexity of the conditions. And confirmatory testing of biochemical and genetic testing will be arranged to see if the baby is confirmed to be a patient or not. So for the genetic testing, it allows us to tailor the intervention to prevent or treat the disease or disease complication. And then usually for genotype that then it can be defined as the DNA blueprint that associated with the clinical manifestation of a trait or disease that called phenotype. And then genetic testing can refer to any kind of testing that determine the individual's genotype. And the purpose of the genetic testing for our IEM patient will be to determine the likelihood of the newborn that has or will develop the specific IEM conditions. And then the extent of the genetic testing can range from analyzing a single variant to a entire genome. And then the appropriate test depends on the indication and the presenting features and the test available of the suspected conditions, and then the available information about the genetic cause of the condition and the presenting symptoms. And then for some genes, there may be only one or two known variant that to be associated with particular condition. So targeted variant will be performed. And on the other hand, for many kinds of genetic disease, the disease gene is sensitive to variation at many locations in the entire gene, with large numbers of pathogenic variants known to causing the disease. For example, like the breast and ovarian cancer genes, the BRCA and the BRCA1 and BRCA2, and then the cystic fibrosis gene CFTR. So testing for the entire gene will be performed. But some diseases, disorders such as the Down syndrome, trisomy 21 are associated with the chromosomal aneuploidies. So testing of the entire chromosome like the karyotyping would be performed. And also the extent of genetic testing can also range from one gene to many genes that some disease are clearly linked to a single gene. And for example, like the hemophilia B is caused by the variant in the F-line gene. And then some diseases that may be so heterogeneous in genetically, and it may caused by pathogenic variants in one of several genes. And for example, like some IEM conditions. So in such cases, usually gene panel testing for known genes associated with the condition is usually considered as effective and cost-effective, efficient and cost-effective. And then if the clinical presentation does not suggest a particular gene or a group of genes, usually whole exome sequencing or whole genome sequencing will be proceed. And then also we need to obtain an informed consent for genetic testing, so as to help the parents to make informed decisions and then to reduce their anxiety. And then we also need to provide enough information about the reason for testing, the type of testing, the benefits and the risk. And then in the pre-test counseling, we need to counsel the parents on the possible results. And then usually for the positive results, the positive findings will confirm the diagnosis of the condition and may implicate the possible inherited nature from the parents. And then we also have to be sensitive about the inherited nature from the parents, because sometimes parents may feel guilty and some have some psychological issues about for inheriting the condition to the baby. And then we also have to prepare them for the need of the Cassell screening, like if there is any affected sibling that need to be tested, and then is it all children with all age should be tested with some genetic testing. And also while for a negative finding does not completely rule out the possible conditions, and also there is a possible result of that variant of unknown significance can be identified, and then that's the meaning about the possible that the genetic variant, the identified genetic variant does not have adequate evidence to prove its pathogenicity. Also, we need to counsel them on the benefits of the genetic testing, includes providing a definitive diagnosis, and then offering information on the family risk, and then identifying the prevention, management, and treatment option. And then we also need to alert parents about the risk of the potential for discrimination based on genetic results, and then also anxiety over some uncertainty on some unknown significant result and the psychological impact on them. And then at the same time, we need to aware of the barriers to that the genetic, some barriers to the genetic technology and services, including culture, language, family values, traditions, religion, and health beliefs. And also sometimes education background or levels may also affect our effectiveness of counseling, because genetic is a quite a complicated topic, and to parents, and then sometimes they some background may affect their interpretation. And then also interpreting the genetic results can help explain to the patients and parents and connect them to some resources and some support. And then regarding after the diagnosis, after with genetic confirmation of the results, the long-term follow-up in the newborn screening is a crucial period for the parents to understand the whole nature history of the condition and on their health and the reproductive implications of the diagnosis. And then it is a long way for them to cope and then to adjust to the presence of the condition, and then to make a sustainable recommended management modalities. And then it is also important to highlight that the role of the nurses to address some supportive care needs of the families, to track the individuals throughout the life courses to ensure continuity of care. So and then I will go to a case illustration of some of the screened out diagnosed patient. And then now we will go to a diagnosis journey of a newborn with primary carnitine deficiency. And then the baby boy was born at full term. The birth weight is 3 kg and discharged home on day 4. And his newborn driver spot card was taken on day 4 of life, and then the result was available after discharge, and the free carnitine level was 3.2, and which is below the cutoff of the 6.4 micromole per liter. And then as we can, low free carnitine levels is indicated for an IM condition called the primary carnitine deficiency, in short PCD. And then PCD raised the awareness in Hong Kong for the first sudden infant death case in 1996, and then reporting a Chinese family with 2 affected infants that presenting with acute onset of illness and were moribund on the presentation. So primary carnitine deficiency is an fatty acid disorder that failed to transport the long-chain fatty acids into the mitochondrial matrix, resulting in the depleted energy production from the beta oxidation. And it is a condition that's first described in 1973, and it is an autosomal recessive disorder. And then the incidence of PCD varies significantly based on the ethnicity. In Hong Kong, it was estimated that to be 1 to 60,000 based on the carrier frequency of a founder mutation. And the dysfunction of the OCTN2 carnitine transporter in the cell membrane will impair the transport of carnitine across the plasma membrane into the cells and the carnitine reabsorption in the renal tubuli. And subsequently, a significant decrease in the intracellular carnitine supply will hamper the transport of the long-chain fatty acid into the mitochondrial matrix and deplete the energy production from the beta oxidation. And primary carnitine deficiency is caused by a biallelic pathogenic variant in the SLC22A5 gene that identified in 1998, and which is located on the chromosome 5q31.1, and which comprised of 10 exons spanning approximately 3.2 kilobases, and encoding the organic cation transporter novel 2 protein, which is the human carnitine transporter. And then at the moment, over 180 genetic variants were described in the SL22A5 gene mutation database at the ARUP laboratory. And usually the clinical manifestation of the patients can vary widely with the age of onset, organ involvement and severity of the symptoms. And then for the infantile metabolic presentation, and affected children can present from between the age of 3 months and 2 years with episodes of metabolic decompensation and triggered by fasting or common illnesses such as upper respiratory tract infection with poor feeding, irritability, lethargy, and hepatomegaly. And laboratory evaluations often usually reveal hypoketotic hypoglycemia, as mentioned by Dr. Zhang, and then the hypoalbuminemia and elevated liver transaminase. And if not treated, the untreated PCD patients may develop coma and die. And meanwhile, for the childhood myopathic presentation, the average age of presentation is between the age of 2 and 4 years with dilated cardiomyopathy, hypotonia, skeletal muscle weakness, and elevated serum creatine kinase. And then death from cardiac failure can occur before the diagnosis is established. So the diagnosis of PCD was substantiated by the biallelic SLC22A5 gene, or a reduced skin fibroblast activities if genetic testing is unremarkable. And then confirmatory testing included the simultaneous, usually when we call back the parents, the babies and the parents, we will do a confirmatory testing involving on the simultaneous analysis of the serum carnitine level and the acylcarnitine level, and then before the initiation of the carnitine supplement, so as to differentiate between the true primary carnitine deficiency or the maternal primary deficiency. And then also maternal PCD can also be detected or picked up as mentioned before, because carnitine is transferred from the placenta to the fetus during pregnancy, and the infant's carnitine levels during the neonatal period can reflect those of the mother. And then therefore these unaffected infants were born to a affected mother can have a low carnitine level shortly after birth, as reflected on the driver's spot card. And then during the pregnancy, a mother with primary carnitine deficiency may have experiences of decreased stigmata or exacerbation of cardiac arrhythmia. So when we interview some mothers with primary carnitine deficiency, they often record when during their antenatal period, they will feel very tiring, fatigue, and then they usually will report those symptoms to us. And at the same time, we also have to be alert that some false positive results of the carnitine levels can be attributed to the maternal carnitine level due to the transplacental passage, and also can be caused by prematurity, malnutrition, or any other secondary carnitine deficiency that caused by other IEM condition. So I remember when I called phone contact the mother for the results disclosure, I asked her about how the baby is doing, and she reported to me that baby was well at home with satisfactory feeding. And then at that time, I asked mother to invite father to also join the phone conversation together for the results disclosure, so as to provide the mother's immediate emotional support, if possible, to the mother. And then afterwards, I discussed the newborn screening result of the low free carnitine, the possible condition of primary carnitine deficiency, and some possible signs and symptoms to mother. At that very moment, the mother paused for with a silence, and then started to burst into tears and cried over the phone, because we called the baby back for an admission and clinical admission. And then the baby was immediately admitted on day 6 of life for the treatment, because factors of infection and poor feeding may trigger the presentation of life-threatening effects of metabolic decompensation. And then before the admission, we also need to advise the mother to avoid episodes of hypoglycemia by frequent feeding and avoiding prolonged fasting, and especially those exclusive breastfeeding mothers. And then I also obtained the family history from mother, and then it was remarkable without consanguinity, and then there is no family history of sudden death. So upon admission, his second driver's spot card before the carnitine supplement dropped it further to 2.58, and then the serum free carnitine levels was only 4.2, and then the lower limit of 19.3 micromole per liter, and then while mother's free carnitine was normal. So the persistent low free carnitine level with normal mother's carnitine level, that it is compatible with primary carnitine deficiency. And at that time, baby showed no signs of metabolic decompensation, and then the carnitine supplement was started, and the serum carnitine level was gradually returned to normal. So at that time, SLC 2285 genetic testing was done for the mother, and then the genetic sequencing revealed that there are compound heterozygous pathogenic variants with 1 missense mutation and 1 nonsense mutation. And then parental testing also showed that parents are actually carriers of the respective variants. And then up till now, in Chinese population, the C.760C to T variant, in fact, was indicated as the founder mutation of, and it is the most prevalent variant in the Southern Chinese. And then for the genetic counseling, since parents are the carriers, and then the recurrence risk in the pregnancy in parents in affected child is 25%. And then carrier screening for the family members and sibling should be done with the targeted mutation analysis method. And the antenatal diagnosis is possible with the known mutation of the SLC 2285 variants. And also the next child will be recommended to do the newborn screening for any early detection of the related condition, and then also carrier screening for at-risk individual, and then with other family members, we will also advise them and then to tell other family members about the condition. So the baby was followed up for 31 months with good treatment compliance. He remains asymptomatic with normal development, and serial echocardiogram showed no cardiomyopathy, and the ECG were normal. And then usually for primary carnitine deficiency, we know that the prognosis is good after the diagnosis and with early L-carnitine supplementation. But although, as mentioned, the treatment responses is excellent, good compliance of the supplement is the key, because there were some case reports of some primary carnitine deficiency patients in China identified through newborn screening finally died with 2 sudden deaths and 1 due to hypoglycemia. And then they were reported that they have discontinued the carnitine supplement. Therefore, it is important to notice the treatment compliance was often poor for the L-carnitine, because most primary carnitine deficiency patients actually had no obvious clinical symptoms. Therefore, detailed information and the importance of the compliance should be highlighted to the parents and their families. So regarding to the implication for nursing education, so after we have go over a case that how we can integrate genetics into our practice, and then we will go to how the implication of newborn screening for the nursing education. So we can see that the newborn screening can act as a model for teaching the principles of public health and genetics counseling to nurses in various stages of education. And we should be prepared and equipped in the bachelor level and the graduate level to respond to the challenge and the increasing use of genetics in the clinical practice, and especially on the newborn screening and its impact of families. As mentioned before, it is not just a test, but it having a whole life impact to the families. And then also there are some actually a number of good resources available online that nurses can use as a reference. It is such as the online Mendelian inheritance in men, Omen. For we can often check the gene information, and especially those known to be disease causing in human. And then another good resources will be the gene review, and it is very useful for information for individual genetic disorder. And on the other hand, newborn screening also bring a various opportunities for conducting clinical and collaborative researches in many areas. And within those areas, research areas that newborn screening that nurses can be involved in, much of the topics are usually along the lines of the ethical, legal, and social implications of the newborn screening, such as the exploration of degree of engagement of parents in the newborn screening program, given the presumed informed consent models, and also on the strategies on how the screening results are best communicated to parents and families to reduce their anxiety, and then to enhance their adherence to the follow-up, and then also some survey on parental supportive care needs. And also there are also some research that support the patients in their transition to adulthood, about the issues of the reproductive decision making and some psychosocial adjustments. And other topics are also related on the biobanking of the dry bus broadcast, the informed consent, and about the effectiveness of newborn screening. And then all these opportunities also foster the development of multidisciplinary research and clinical teams. And regarding to the new screenings on the horizons and future, and there is a ongoing movement in incorporating whole genome sequencing methods, which reads the entire genome of individual into newborn screening process, which can actually use as the confirmatory and follow-up testing related to a positive or ambiguous results from initial mass spectrometry-based screening to lower the false positive rate. And then also the new technology in the newborn screening also advances the field of the personalized medicine. And then as a result, there is a increasing need for the additional public education, research, and medical and nursing education to meet the demand for the newer screening process. So here are some useful websites for newborn screening information and education. And then as mentioned during the previous session in my presentation. Okay, to sum up, the newborn metabolic screening is a very effective and beneficial program for the timely management and detection and for early diagnosis and treatment of IEM patients. The genetic nature of most of the conditions included in the screening panels necessitates that we nurses should be competent to integrate genetics in their clinical practice, and also nurses have a very important role from the pre-newborn screening, disclosure from the screening screening results and in the long-term management of those diseases. And also we are one of the key players in the advancement of genetics and genomics. And nowadays, nurses, the field of nurses in genetics and genomics you are in a great potential of development. And then also it is my pleasure to work in our newborn screening team and our pediatrics genetics team. And then it is my pleasure for me to also accompany the parents to go through their ups and downs during their diagnosis process. And also seeing those children can grow and thrive has always been my motivation to work. And then that's the end of my sharing. And then thank you very much for all your attention.
Thank you, Diana. Very detailed description of what you're doing now, right? And any questions? Right, Diana, may I know if there any patient support group for them? I think, well, will it be more easier and more convincing if parents themselves can form a group and share their experience?
Yes, actually, there are various patient support groups that we can find. For individual diseases, such as sometimes may not be not limited to IEM only, but other rare disease like the EB, the dermolysis bullosa, also some there are also many various kinds of patient group that they can share. And then usually for the skincare, about the support group of the related skincare parents, they can share their experience on how to take care of children's skin condition and many life living tips they can share. Yeah, so there are really various kinds of support. And then also for our CUHK program, we screened out a few primary carnitine deficiency patients. And then we also will try to link the parents up. And then because one of our primary carnitine deficiency parents are quite worried about the diagnosis of their children, so we referred it and we recommend them another family that with primary carnitine deficiency to meet up together. And then finally that worrying mother becomes more reassured after meeting those other families or parents that also suffered from the PCD. So it does help, and it really helped. And then we always try to do those liaison between those families if possible.
Yeah, I see.
Yeah.
Good. So one audience asks you if you can show the website again.
Or
the screen. Yeah. So
okay.
Yeah.
For
one? Yeah.
Yes.
Yeah.
And there are on this slides there are many credible resources for the newborn screening and information. And then also other than this, I would also like to show again this slide for the good resources regarding on genetics, and it is about the omen and the gene review, and it is very useful, and we constantly use for during our clinic because we really need to do some extensive reading about the condition before we see the patients, and then before we counsel the patients on those genetic tests, because especially on the gene reviews, because we need to prepare what kind of genetic test to tell parents. And then parents usually may ask why we need to check those genes, or why I only check one gene, or why I need to check a few kinds of genes. So they may have some question about those genetic questions. So we also need to be those questions need to be addressed.
All right. So another question. Is the WGS or WES actually necessary to newborn screening, owing some novel findings which might not clinically related or lack of clinical evidence, I think. How do doctors and counselors deal with these results?
Thank you very much for the questions. And for the WGS or WES based newborn screening, as I know that, at least as I know that Hong Kong, Hong Kong so far haven't got any implementation about this genetic-based screening. And however, as previously Dr. Mac introduced us that it will be less controversial if we include those disease with known pathogenic variants. We do the sequencing, but we only look at those pathogenic variants, then it will be less controversial. And then we may look at those disease with with high penetrance and high expressivity. So it really depends on the screening panel about the genetic screening on the newborns. Yes.
Yeah. So next few questions more. And what is the advice for the parent if they have an IEM problem baby and they in future pregnancy, can they arrange IVF in government? Yeah.
Usually for those parents with, it really depends on which kinds of IM conditions that the child is suffering, because as Dr. John mentioned before, and then some conditions actually can be improved by a very simple diet modification or some simple supplementation like the primary carnitine deficiency, and then or citrine deficiency can be just modified by dietary modification, and also needs to consider as the acceptability of the parents about the condition of the child on the next pregnancy. And then if those conditions may not be so significant or the parents' acceptance is high, then maybe we will just advise them to go on newborn screening on their next pregnancy. However, there are really some conditions that really serious, like the carnitine, acyl carnitine translocase deficiency. So for those cases, if they really the parents really would like to seek for PGT or IVF, then they can tell given the confirmed diagnosis of that child, they can the lady can request their OG doctor to write a referral, and then to the OG department, and then to seek for the genetic counseling and the IVF arrangement of the PGT to do the pre-implantation genetic testing for the monogenic disorders. And then also we also need to have the assessment and the genetic consultation with geneticists, and then also need to counsel them on the indication on the IVF, and then also on the indication on the PGTM. Okay. So they can also seek support and consultation for that.
So one more. Is targeted sequencing with non-clinical related targets a better option?
So it really depends on the presenting symptoms and the condition, because as mentioned before, sometimes if only do the some disease may really have the specific one or two loci that having causing the condition. However, most cases are usually sometimes one gene, one targeted sequencing may easily be missed. And also usually targeted sequencing we usually use in some family cascade screening when the particular known mutation is found, and then usually we will just proceed those family cascade screening on a targeted basis, because we may not want to have any other incidental finding or other findings through those tests.
Right.
So targeted sequencing can be used in some particular disease with known 1 or 2 only pathogenic variants, or used in the family cascade screening that already with the known mutation that inherited in the family.
Oh, yeah. Next question is that screening conduct in all public hospital. I think so, but we have the universal screening now for the in all. Is that or by invitation? Will you confirm the answer? The participants asked, is this screening conduct all infant born in public hospitals or by invitation?
Usually, maybe I will describe more about usually for the babies that born at the time moment, baby born in the public hospital will follow the government metabolic screening programs, and then to arrange their newborn metabolic screening at the HA hospitals, and then however, some babies are born in the private hospitals, and then so for the babies in Hong Kong born in private hospitals, usually it will be their parents' option to see if they would like to proceed to the newborn metabolic screening. If they would like to seek for to do the newborn metabolic screenings, they can do the sampling at like any one of the private hospital. Then the private hospital will send the sample to our center to do the testing, and then we will release the reports to them, and then to do any follow-up for the any abnormal results.
That means parents who give birth in the private hospitals can opt in.
Yes, exactly. Yeah,
Thank you.
Thank you.
I think the last questions. Babies with IEM conditions will continue to have follow-up for how long?
Usually it really depends on situation, and then usually lifelong, because as we know that IEM disorders are genetic defects with some deficiency in some enzyme. Therefore, sometimes the treatment or the lifestyle modification or the diet modification usually lifelong. Therefore, they need lifelong follow-up at the metabolics clinic, and then also there will be transition of the clinic from an adolescent clinic to the adults clinic, and also the continuum and the transfer of the caring is also a very good topic for research on how to do the continuum care better. Yes.
Thank you. So
thank you.
I think this is the last questions. And okay, Diana, will you switch off your PowerPoint first? And we're going to show the QR code. And
Okay.
yeah. Okay, before you leave, now the QR code we are going to show is for the local medical colleagues for the CME accreditation only. And for overseas participants, local nurses and midwives, you please click the link to confirm your attendance. The link, which has been sent to you in the previous confirmation email, the confirmation of today's event. You can click the link there and to confirm your attendance. And then 2 days later, we will send you another email to invite you to give your feedback. We really appreciate your opinions, and so to improve our future seminars. So is the QR code already available? It's coming. Yeah, it's here. So welcome to join this book seminars today. Okay, enjoy your weekend. Hope to see you soon by face to face. Stay healthy and prosperous. Thank you.
Thank you.